this woman needs no introduction really. This is Dr. Laura Marshall-Andrews, whose vision, along with Gary Toyne, our practice manager, started this practice 5 years ago, and we all thrive with Laura and Gary having holding this vision of having integrated healthcare and with an emphasis on living well. And Laura has been involved talking in national conferences around social prescribing, which is one of the subjects Matt Hancock brought out in recent months, and best placed person to tell you how that affects all of us and what's going to happen at BHWC in that context. So welcome, Laura, and thanks very much.
Thank you. Thank you all for coming, despite the weather. So I'm just going to quickly try and give it. We wanted this to be a political forum with the local politicians, and we asked Peter, Kyle, and Caroline, but they're all very busy at the moment. So I'm just going to try and give you a bit of context to general practice, and in particular what we're trying to do here, and how they relate together. So this is the basic sort of problem that we have. Each general practice in the country receives a global sum, which is £70 per patient per year, to supply all the primary care needs for that patient. And this came about 20 years ago, and it was based on each patient attending their practice on an average of sort of less than one visit per year. That's completely changed now, and the average patient comes to the primary care clinic in the UK about 5 times a year. Across the world, we're still quite low on that. In Japan, the average is about 13 times a year. In America, it's 3, but that's probably because people can't really afford it. Yeah.
May I ask a very quick question? Sorry,
sure. No, it's fine.
Can we get this information anywhere? I'm just asking as a candidate for the local elections.
Oh, yeah.
And I'm really, hoping to gather some information, certainly for our doorstep. We're talking to
sure. I can really send you this if you want, but a lot of this is from just national statistic places. Yeah.
I won't keep asking. As I noticed, it's quite old, 240, but regardless, the £70, could you just explain, is that including staffing costs, functional costs?
Yeah.
I guess if you go to the supermarket and you buy a basket of something and they're £20, that's what it costs you. So is it like that? Everything?
Yeah.
The whole.
So that's we get the global sum, which is paid to us, and that is a function of how many patients we've got, and it's £70 per patient.
It's not staff salary.
And we have to pay all our staff salaries from that. Yeah, exactly, and then the equipment and everything like that, all the bandages and everything, so I think it probably costs around £70–80 for one 10–15 minute appointment. So you can see that it's not working. We're not able to. That's why when you try and phone up to get an appointment, it's really hard to get through, because we don't have the resource to supply really what people want. That shouldn't be there. So this was the government's response to it. They can't just increase primary care funding by 5 times, because that would just be sort of the entire gross national product probably. So the government have decided what they want us to do is to work at scale, on the principle of economies of scale. So by 2021, they want to see these large primary care networks, basically of between 30 to 50,000 patients in each one. And they've sort of thought about that because this is the size of a small village. And that's kind of how people can sort of relate to each other in that group. Personally, I think there's a lot of problems with that because it creates, it lends itself much more to very protocol system-driven healthcare, which is very depersonalised. So, you know, we have a problem with continuity anyway, but it's going to make that a lot worse. So it'll be very hard to have the sort of personal relationship that actually is, I think, the bedrock of really good medical care, and the doctor-patient relationship is everything.
I just have a question. How many patients are registered here now?
So there's 14,000 patients here, so that would be, you know, that would be kind of twice, more than twice. It would be like us and Charter together. Charter have about 27,000, and they're a very, very big practice. Yeah. So, and apart from the implication to the patients, you know, of having such a big practice like that, there's the King's Fund here have done quite a lot of research with the Health Foundation, and they just are very concerned about the state of the NHS workforce and our ability to actually deliver that, because of the changes that it would require. The other thing about working at that sort of scale is that really, in lots of ways, when we had little practices that had district nurses, health visitors, mental health workers, all in the same sort of little building, and we were serving, you know, a few thousand patients, you knew the district nurse, you bumped into them in the kitchen, you talked about patients, you really understood with each patient who was involved in them, and you had contact with them. The difficulty that we find now is that everything is so big that it's very difficult to connect with the individual person who might be going in to visit one of your patients. So you're sort of, a lot of the time, you're kind of practicing blind, it feels like. So you can look at it in the government sort of sense, which is to try and, like, you know, address it in economies of scale, and continue to look at things in a very pharmaceutically driven solution. So what they're looking at is create these big primary care hubs. Then you've got, you know, if you've got high blood pressure, you need to be on these drugs, you need to have this monitoring, you need to have these blood tests, and that's it, you're done. But actually, we're not in a position now where we're going to be able to kind of medicate our way out of this. And that's largely because many of the health conditions which people are coming to us with 5 times as much as they did before are related to lifestyle, community and social issues. So,
RCT?
Sorry. So RCT is a randomised control trial, yeah. And so what's happened to medicine is that over the years, sort of over the 20, 25 years that I've been practicing, this has come in. Well, the name evidence-based medicine has come in. I mean, we've always been using evidence, but to kind of worship this god of evidence has become a relatively new phenomena, and it's very tied to double-blinded randomised controlled trials, which is mass data trials basically. And there's really only one thing that you can trial like that, and that's medicine. So you can only really trial tablets or injections in that state. So it's very pharmaceutically driven. You know, it's really impossible to trial acupuncture or osteopathy in that, because obviously people know whether they're having acupuncture or osteopathy. So I think that these are and we think here that really that this has got to be looked at more, and that the way that we can sort of support the health service and provide much better care for people is really to try and address these things, because a lot of the time we're medicating people's lifestyle and social situation, breakdown of communities, you know, breakdown in our social structure. And I misplaced this quote, this thing, but it's here. So loneliness and social isolation has really been very well trialled now, and it's been shown consistently to be a very high indicator of increased mortality and morbidity. So we should really be assessing people's social connectivity as much as we're assessing their cholesterol and their blood pressure and everything else. So this is just a few more things like this. So yeah, again, just saying they did a big study in California, which also pointed towards loneliness and social isolation as being one of the biggest sort of markers of all morbidity really and mortality, but particularly cardiovascular. And then these are just some sort of theories about why it makes such a big impact on your health. And there's certainly, you know, there's this sort of the physical ability to do things, your mental state, you're likely to be lower, more depressed, less resourced. But there's also a sort of a very measurable physiological sort of biochemical change that your body goes through when you are lonely, isolated, and low. And this is also a very big part of why loneliness is a big problem and really needs to be addressed if we're going to try and ultimately make people happier, healthier, and less reliant on the health service. So these are 2 chromosomes, and this is this young, lovely chromosome here has these very big sort of red bits on the end, and what they are these things called telomeres. And telomeres this is a nonsense part of DNA, which is at the end of each chromosome. It's a bit like the sort of plastic bit on the end of a shoelace. It protects the chromosome, and our cells are dividing all the time, and they need this bit here. They've got a little thing that works its way along here when the cell is dividing in order to replicate the chromosome, and when it comes to the end, it needs to be able to replicate all the important DNA without falling off the end. So this bit here is really important for it. So if you've got nice long telomeres like this young little chromosome there, then the cell which has these chromosomes in it is going to be able to replicate well and you know, a number of times. Each time it replicates, it will lose a little bit off there, like this one. And there's an enzyme called telomerase that builds it back up again. And if you put a cell into a solution of telomerase, it will continue to divide forever. So that cell will become immortal. So it sort of defies the aging process. Normally, as we get older, our telomeres gradually get shorter and shorter, and that's why, you know, our skin loses its tension and its collagen, and our bones start to become more brittle and things. Now, this enzyme telomerase is very, very affected by stress levels and your mood. And there was an amazing woman who won the Nobel Prize called Elizabeth Blackburn, Professor Elizabeth Blackburn. She did a lot of work on telomerase and things like yoga and social connection and happiness increase your body's levels of telomerase, so you're much more likely to be able to live longer, to be resistant against cancers, heart disease and things like that, than if your telomerase is low and your cells basically age faster. So that's another kind of physiological effect that your mental state and your social connectivity has on your body. So with all of that in mind, what we decided to try and do here was to create other options for our GPs and clinicians here to be able to help patients, not just to deal with their high blood pressure by taking Ramipril and their cholesterol by taking statins, but to try and help all of those other things that we've just talked about. So we created the Brighton Health Foundation. We teamed up with some amazing therapists, 2 of them who are sitting over there, and some artists, and just basically started to try and see how we could work together. This is one of the first interactive boards that we had here, and we asked people, you know, how can you, what do you do to make yourself happier? This is in conjunction with the Action for Happiness. This is a great local group. And we got some great responses there. That was one of my favourite. Naked trampolining.
Oh, trampoline.
Yeah, playing the trumpet, smoking weed. I'm not sure about that one. And we got a lot of artists in, and started being involved with the open house. The artists started doing, you know, some of the art therapies that we have, and narrative workshops, drama groups, and so on. This is a really lovely picture done by one of the artists here about her sort of journey with chronic pain, and what it felt like. That was another one, that was one of my favourite ones actually. Yeah, it's really powerful, isn't it? And then this isn't a terribly good slide, sorry, but these are now the 9 arts group things that we have here. So we've got, sorry, I can't read that at all. We've got, oh yes, art therapy, is that drama? We've got narrative workshops, we've got the book group. We've got the photography walks, we've got the drama therapy, playing with paint, and have I missed anything?
Naked trampolining.
Naked trampolining! I knew there was something missing from that list. Singing for Health, yes, exactly. And this is our singing group, and they've been going for ages, and I just love them being here every Saturday morning, and often I come in and sort of catch up on a bit of paperwork, and it's just really joyful. And there's huge amounts of evidence now really around how singing is really good for your health. And this is just a bit of feedback that we've had from different people along the way who've been part of the different groups, and it's really made a big difference. I think these are mostly the narrative workshops that we ran here. We're still running in. They run in the term time. They run sort of for a term of 6 once a week, and people come and you read a poem or a piece of narrative, and then you discuss it, and then you write something yourself. What's called in the shadow of the text. So in the sort of feeling that reading that poem or whatever has generated in you. And it's a really sort of cathartic way to experience things that are bothering you. We run one of the narrative groups is particularly for people who are in recovery after substance misuse. We've got lots of patients with substance misuse here. We're in the middle of these 4 big hostels, homeless hostels, and you've probably passed people as you were walking here this evening, and most of them are our patients. This is the film and dance group, Finding Your Compass, and they've done some really great work with patients who initially, I think they do some drawing, and they do it at the Old Market. They do it kind of dance, which is then filmed with the animation. It's kind of put over the top. And to start with, all of the patients said they didn't want their names put on the film because they didn't want to be identified. And by the end of it, they all said they really did want their names to be put on the film. So yeah, there's just some feedback about singing. So for 5 years, or 5 years ago, we were really out on a limb. We went to the CCG to try and get some money to help us revamp the practice so that we could start all of these things, and they said no. And throughout the whole time, we've tried to approach them for funding and things, but they've not really been able to see the advantage in it. but this has just started to change in the last kind of year, and we were there was the first national social prescribing conference. So social prescribing is really the name that has now come and been given to what we're doing here. So prescribing other things other than medicine, really. So arts and other forms of well-being activities. And yeah, we were held up as a kind of beacon practice. Matt Hancock, who knows the new Minister for Health, he gave a very impressive keynote speech where he pledged to support social prescribing and increase the budget of arts and health and stuff. I mean, whether that actually comes through or not, who knows? But it was really encouraging that he stood up and said that in front of people. And yeah, there's this was one of the statistics that kind of he used, and I think this is probably why they've all cottoned onto it, because every pound that you spend on arts and health, they think saves the NHS £11. Yeah, so that's a pretty persuasive argument. So what we want to know now is will his investment and positivity about it trickle down into our CCG so that they might kind of get behind us.
CCG stands for?
Clinical Commissioning Group. Yeah, so it's what used to be the PCT. Yeah, so that's it. I hope that's been helpful. It's yeah, I mean, hopefully we'll see some of this come through, but who knows? With the big B, we just don't know what's going to happen. Yeah.
If you said two politicians you mentioned from this area,
Yeah.
had they come,
Yeah.
what would you have put things to them, given like this, and would you have expected well, I guess you would have wanted a response.
Yeah, that's a good question. I think.
How would that have panned out?
Yeah. I think what I would have been trying to find out is what their opinion on social prescribing is, and you know, whether they think it's a worthwhile thing, whether they'd be prepared to support it to help lobby the CCG, that kind of thing, really. I know that Caroline Lucas has always been a very big supporter of ours and of social prescribing, and I think Peter Kyle probably is as well. I know that I go to quite a lot of the other groups, like there's an amazing table tennis group down in Kemp Town, which is just fantastic. It's really good, loads of
Does it keep teenagers off the streets?
Yeah, and you know, we've got a couple of patients with Downs here who go there all the time, and they just love, you know, spend their whole time there. They really get that balance right of being accessible, but also being really well done, very genuine, competitive, you know, all of that kind of thing. So it's there's lots of different sort of projects here which are excellent, which, you know, feed into social prescribing. But one of the reasons we want to do it here is because for people who are very vulnerable and or very unhappy or low or isolated, actually going somewhere else is it's a big deal. It's quite difficult. Whereas if we start them off here, we know they'll come here. They do come here, and then they can maybe start and join a dance group somewhere else. Yeah.
Just some personal feedback, really.
Yeah.
Whenever I say I'm a patient here,
Yeah.
if patient's the right word,
Yeah.
at the centre, everyone is amazed and says how lucky and fortunate I am.
Oh.
And I certainly feel that way. I came from London about 8 years ago. Yeah, this centre has been an excellent experience, I must say.
Thank you.
And I am both of us are standing as local politicians, so we're desperate to know, for example, when you say that you've received barriers or it hasn't trickled down to the clinical commissioning group, we as local we might well be councillors, if
Brilliant.
I may.
Get in.
What are the barriers, and what have you faced from the clinical commissioning groups? Because I thought as clinicians you would have an impact more than others, so it would be interesting to find out what the barriers are with our specific CCG, as far as you can say.
Yeah, no, and exactly. It depends entirely on who is in the CCG. So there are some CCGs, and I think the one that's sort of held up at the most is the Maidstone and Medway, somewhere around there. And they've invested, I think, about 400,000, nearly £500,000 a year into their social prescribing budget to really kind of boost these projects. And they have halved their hospital admissions and made enormous kind of inroads into people's health and their local hospital, which was really struggling. So they've kind of led the way on that, but it's very brave, because what tends to happen, my experience, is that the people who make the decisions with public money don't want to do anything that's very new or different in case it goes wrong. So they'd rather do something that doesn't really work very well, but at least it's been done before and they can't really be blamed because there's a precedent for it. So actually getting people to take a risk and do something is quite difficult. Now, I hope it's got to the point now where it's no longer risky. You know, I think it's so well trialled now, and they've got precedent in other areas that hopefully now the CCG will do it. Yeah, sorry.
Yeah, I have a few questions. I understand that Michael Dixon.
Yeah.
He's got a seat, or
He's the lead of the social
So
prescribing.
so I assume there are national guidelines that the CCG would also have to consider, or is it not so?
No, so he is. He has a role which is an NHS role in social prescribing, but it's more about, you know, trying to increase awareness of it, trying to help CCGs and stuff. But there's no mandate that CCGs have to do anything. No, no, they can sort of do what they like.
And then I have another question.
Yeah.
Because in order to persuade people who think in a very conservative and traditional way, it's always good to present some figures to give them more confidence that they're not going to make a loss. So my question is, are you kind of having any figures of what's happening here? How your social prescribing, what effect it has had? Not just feedback from patients in what they are saying, but there are also additionally figures on how that has impacted on.
Yeah, so that's a really good point. The figures that they're interested in are hospital admissions and visits to the general practice. So we have got some data around patients that have gone through that, and it does show, the data that we have got, which was actually quite early on, that there's a sort of an overall reduction. It's quite difficult because we're so small. It just takes a few people who sort of get more ill, or something, they get hit by a bus or something, and then it sort of skews it. Yeah, but overall, it definitely did show that. We also do have the lowest hospital admission rate per. It's called something like AI, which is they look at how they sort of standardise your patient population, and we've got the lowest hospital admission rate per sort of serious chronic illness in the whole of Brighton. So whether that's to do with, it's quite hard to do cause and effect like that, but we definitely have. So
I want to ask a question, or not say something if I may. Can I just ask the two people here first, which parties are you standing for? Because it must be a party, isn't it?
Yeah, I didn't want to say that
Well,
because
I'd like you to
I
say
didn't
it.
want it to made a party political.
No, I'm just asking out of interest.
But since you've dragged it out of me,
Okay.
I'm standing for the Labour Party
Thank you.
in Brunswick.
Thank you. And yourself, the lady here?
I'm Lady Sue.
Anyway, that said, thank you very much for imparting that. Last year, and when I think it might answer something, though I say I'm not nothing to do with politics. I have been involved as a little ordinary person. When I made a phone call about something, and I found out by chance at the low vision clinic, which is more a physiological type of thing, was going to lose its funding, and I had a meeting with the CCT, with another organisation, and just so you understand, what they would say to us, or people, we only now have to deal with statutory stuff, and it wasn't a statutory item, which might sound astonishing, that people with low vision and AIDS or what have you. So what's happened is Brighton Hove City Council has taken it for 1 year. It used to be covered there, but whether they'll retain it, and they've reduced it down from what was a wider catchment area, which was Lloyd Russell Miles, and further afield to just Brighton Hove. And that's giving you one example of several. And again, with Brighton Hove Walk-in Centre, I'm trying to find out when they're going to have the consultations, but it's really hard for that to get information. And though the people I've met are quite pleasant, I find it quite obtuse. And even with Caroline Lucas trying to follow something up, like, it's very hard to get the answers, and the same with Lloyd to some extent with Labour. So that's what one's up against, and I'm only a little lowly person because the purse seems to be getting smaller, though they come out with the statutory, and I guess if it's statutory, that's all they have to do, isn't it?
And I
So
think
I'm
it's
not trying to be miserable, but just
no,
what
I think you're right. I think that is the kind of current climate. Oh, well, let's hope that things will change. But I think if we can just approach things in a different way and use what we do have, use ourselves and our community, and because that is so powerful as a way of kind of supporting each other, making ourselves feel better.
Just go back to something else about loneliness and the different causes. Could it lead to dementia?
Because the brain training, well, we've got our sort of dementia brain food expert over there.
Assessment and treatment service, and I developed a project in that service in London, it is, on lifestyle, nutrition, sleep and all that. And every thought you have creates a hormone, and that's quite a thought. That every thought we have, it needs to be linked to a nerve transmitter, to a hormone. And also every body sensation we have is because it's our inner communication system. To me, it's like the software of the computer.
That's right.
It's always communicating. So if I'm isolated and I don't have a relationship, then I am confronted with my own thoughts. There's nothing new.
And your neural pathways aren't, they're not being used in the same way, and they need to be used to keep going.
So it's,
Oh, mute this way. Oh, sorry. I thought there was someone over there.
There is a strong relationship, that social connection and learning new skills is very important. And health is relational. We need relationship.
Yeah, absolutely.
One of the political things everyone can do is that we are very concerned that the health and overview is, because as a local,
not a lot of it.
as a local authority, we only have a scrutiny function when it comes out to the health service. Hopefully, with a new government, that might change. But if it doesn't, we have a scrutiny function. But one of the things happening in this area, which we're objecting to, is that the health and scrutiny function now, rather than just being based in Brighton and Hove, as we have, and something we were promised we would keep when we had City Council status given to us, is that the scrutiny function is now going to increase over the whole of Sussex and Surrey even, which means our ability as local councillors or whoever sits on the scrutiny board to affect local services is ameliorated. And I think there's a big push, if I'm correct, from NHS England to make things much bigger and regionalise functions.
So you lose that personal.
Yes, and so we lose as a city our ability to scrutinise the health service and provide the overview function. That's the recommendation that is going through at the moment. We're very much against it, but of course we're fighting against other authorities that would prefer that. And of course we as a city are very distinctive, say to, pension or other areas in terms of health, and we need to keep our own health overview and scrutiny. So that's one of the things that we'll be fighting for.
Yeah, great. Yeah, thank you.
I said I wouldn't, but the last thing, because this gentleman was looking to go into politics, and I don't know if you've any opinion, and I will say it without what was my opinion. I would invite to something about older people. There is quite an elderly population here as well as a young one. And it was earlier, obviously last year, and it was about the toilets and charging 30p. And people I was with from an organisation, I went individually, managed to get the councillors to unvote it, and then again they brought it up a few months later. And for me, again, I think that's very bad. About 12 or 13 of the toilets, it's going to be 30p. Now, if you've got homeless people that might want to use the toilet, you've got the elderly with more continent troubles and what have you. I know that's a minor thing, but some of these things just make me seethe so much because they're not thinking
I
for the
agree.
good of people.
Yeah.
Sorry,
I agree. No, don't be quiet. And I think, you know, you're very powerful, you know, we all are in our little way, and that, you know, the people, we should behave as though we are, you know, because they do need to listen to us, and people can. Yeah. Oh, that's a shame, isn't it?
But they've done that with other stuff. Sorry.
Yeah. Oh, well, carry on going to those meetings and.
It is rather draining.
Yeah, I bet. Yeah.
I just thought I'd point these things out because the public don't
They make a big
know
difference.
what's going on.
Yeah.
That's the thing.
No,
with
that's
lots of
right.
these things,
Yeah.
unfortunately.
No, I agree. Any other questions?
I'm curious whether people are self-defining as lonely, or how it must be a very sensitive area for you to kind of probe the person in front of you.
Yeah.
I'm just thinking that some people,
Yeah.
I'm thinking of my ex-husband actually,
Yeah.
who chooses a very isolated existence, and he would be horrified if you suggested that you're lonely.
Yes.
It doesn't seem something that way.
Yeah.
But I just wonder, do people actually sitting in front of you say, I'm lonely?
Yeah.
They do.
So I think I completely hear you, and I think, you know, this isn't about, it's not like a sort of public health economy drive to make sure that everyone has to, you know, meet up in order to boost their telomerase so they don't come to the NHS. But it's more just, exactly. It's more just to say that, you know, I think as clinicians we've been very unaware of it, or we're aware. I think all of us GPs would say a lot of people come to us and they are desperately unhappy and lonely. And a lot of, you know, I had this one lady a few years ago who lived in one of the sort of streets up there, and all she wanted was to be able to get out and just go for a little walk with a friend. Now, could I get that? You know, no, I tried physios, we tried, actually the befriending service were good, but she was quite unsteady, and, you know, really she just needed some friends to come round and kind of help her and, you know, bring her out. And I mean, the singing group are great here because they will go, some of them will go to people's houses and kind of help them down here and things. And it's more, it's not kind of saying to people, you know, you're lonely, not like, you know, you're smoking, you've got to give up, you're lonely, you've got to get out more, that kind of thing. It's more just trying for us to be more aware of what we can do to help people who want to be helped. Yeah, exactly. So people who are sitting in front of us saying, I am so unhappy, that there's things that we can offer them other than citalopram or, you know, a medication.
So what's the, sorry, I don't want to dominate the thing. What is the future as you see it? Do you carry on carrying on, doing what you do right now for the time being? Are there any plans for widening the scope of it?
Yeah.
Is it possible?
I would love that. And we're sort of constantly trying to look at different ways. We had a conversation with the council, in fact, years ago, about trying to build an amazing thing down on Black Rock. But I mean, there's money, there's will, requires a lot of that. And So we'd sort of decided that what we wanted to do was just to put all our energy into this practice and try and model something, just to say that it can be done without a massive investment in a huge sort of, you know, new building, that actually you can do it like this. But, you know, I would love to extend it. But I think for the moment we'll just kind of keep battling on. And just thank everybody who, you know, was here. If you contributed to the practice, to the crowdfunding, for being here, for being sort of part of it. That makes a big difference to us. So
I mean,
thank
I feel
you.
like I've just moved from Wales, I've only been here a year, and I couldn't believe my luck when I found this was my practice. I just think it's brilliant.
Oh,
So,
thank you.
Really
That
Thank
means
you
a
for
lot.
putting on this weekend. It's really
Yeah.
fantastic.
Well, that's Carly, really. That's our hero, Dr. Grindy over there. Yeah. Oh, thank
It
you.
looks like it's oversubscribed, you might have to do it again, mightn't you?
Yeah, well, we think, yeah, I think we'll, yeah, we've got lots of ideas, yeah. Yeah. Great, well, thank you so much.
Thanks, Laura. And just one thing actually, if you want to know more about social prescribing, we are having a social prescribing session at 12:30 tomorrow. So